Today on the podcast, we have the lovely Jaclyn from the Lost Labia Chronicles joining us. I am so excited to actually have her back on the podcast because she's been here before. Jaclyn is a super advocate for us in the lichen sclerosus community, and she is actively involved in LS research, and her passion to advocate for the community really shines through in everything that she does. Today, we talk about topical steroid treatment and the steroid ladder, why clobetasol isn't the only option, how potency, frequency, and texture matter, navigating maintenance versus flares, moisturizer choices, and why what works for you is what matters the most, the difference between signs and symptoms, what remission actually means, and why pain can still exist even when the skin looks healthy. And we're talking about so much more. This episode is truly epic, so let's dive in. Welcome to the Pelvic Power Podcast. My name is Penny, and I am the host of this lovely space. I am a pelvic floor yoga teacher who teaches people with pelvic pain how to use movement, breathwork, and body awareness to ease and manage their pain while living a pleasurable life. In this space, we'll be talking about all things taboo because we love it, and how to support your lovely pelvis and your lovely self on this journey that you are on. I'm very happy that you are here, and I hope that you enjoy this episode. Welcome back to the Pelvic Power Podcast. I'm very happy that you are here today. Today we have the lovely Jaclyn from the Lost Labia Chronicles joining us on the podcast. This is our second time on the podcast, and I'm so excited that she's here to talk all things about lichen sclerosus. Welcome, Jaclyn.
Thank you so much, Penny. I'm so happy to be back. Thank you again for having me.
Oh, thank you so much for being here. You are truly such a gem in the community, and I know that so many people are really excited about this episode because they've already told me, and I'm very excited what we're going to learn about lichen sclerosus today, all thanks to you. So first off, thank you for everything that you do for us. We appreciate you so much.
Thank you. Thank you. You're so sweet. You've always been such a huge supporter of my work from like the second that I kind of started on Instagram. You were always so like encouraging and sweet. So thank you for that.
Oh, well, it's important. The work that you do is so important for many of us, so it's important to highlight it, and I feel like more people, we should talk more about lichen sclerosus. So I'm happy that we're doing this and just bringing more light onto this topic. So yay. Let's dive into it. Okay. I asked the community if they had any questions for you. So these questions are not from me, they're from the community. So let's dive in. So the first question that we have, we're going to get straight into treatment here. Clobetasol is applied 2 times per week. How often for less potent steroids? That was the first question that I got.
Okay, so that will depend on the potency of the steroid in question, and that will also depend on how your skin looks clinically and where you're at symptom-wise. So a part of that would be a discussion with your healthcare provider, and then again, it would depend. So on the lowest end of things, you would have something like hydrocortisone, which you could get, we're both Canadian, so I'm going to say like Shoppers, but for anyone else like CVS or something, a drugstore. You can get it there, right? There's no prescription needed. It's very, very low on the steroid ladder. That typically you would, even in your maintenance phase, you would apply that every single day. And so, you know, in making these decisions, sometimes we have to think a bit about our lifestyle too, right? For some people, they don't mind doing a lower potency every single day. It doesn't bother them. It takes them a couple of minutes and they're like, yeah, all right, we're done. For some people, they don't want to have to think about that daily anymore. They really want, you know, I mean, maintenance phase really is 1 to 3 times a week. So anywhere in there, but they're not doing it daily. So they're like, oh, it's a lot better for me. But yeah, it really will depend on the potency. So like that's at the weaker spectrum. Something in the middle might be, you know, it could be 2 times still, depending on how your skin looks, depending on your symptoms. So ideally, you have a good physician that can really look at the skin, hear where you're at symptom-wise, and then dose you accordingly. But it could be, you know, 2 to 4 times in the middle and then daily for the like super weak ones.
So people are on the lower potency version without any prescription too, like they're using that instead of steroids, for example. Is that a thing?
I definitely know some people that do. So I'm thinking of one individual in mind. Obviously, I'm not going to name their name, But what they do is, so they initially did treat with topical corticosteroids, topical clobetasol. They treated with that and they did that daily until their skin kind of got into clinical remission and their symptoms abated. And then once they got into that kind of place where you're kind of things are good, both clinically, the skin looks good and you feel good, then she just kind of dropped down to the weaker one, which is the hydrocortisone, and then she uses that daily. She has a tube of clobetasol for if she flares.
Okay.
So she just kind of that works for her and her body as well as her lifestyle. So that's what works for her. Great. And then she has that tube of clobetasol so that she has that higher potency. If symptoms start to flare again, then she'll kind of go on that flare protocol, which is typically you're going to go back to your daily usage for about a week or two, depending, and then you reassess, go forward. And then once the flare kind of abates, then she would go back down to the hydrocortisone. I don't know that that one is like a super popular thing for folks to do, but I definitely know a handful of folks that do. I think it's more common to be on something kind of like mid potency, something like triamcinolone or something like that. But even folks with triamcinolone, their maintenance is typically still going to be two times a week. It's really when you get into the super low that you might have to kind of up that frequency.
Yeah, I just get so impressed with you being able to say all these names. I'm like, every time I try to say one of the steroid ointments or anything, and I'm like, I'm just butchering it. I don't know what I'm saying. But the one that you just mentioned, try some of the.
Triamcinolone. The key is confidence. Just pretend that you're
Okay,
saying it right. Like I
okay.
might be mispronouncing some words.
We're just going with it.
I'm just like, it's triamcinolone.
Delulu is the Salulu. That's what
You
we're
know?
doing.
Yeah.
Yeah.
And it one day if I hear someone say it differently, I'll correct myself. But until then, it's triamcinolone.
Yeah. Is that's a steroid, right?
It is, yes.
Yeah, yeah. So what
And
are
it's
the
actually
most
pretty common. That one's a common one that I hear a lot of people are on. And that's the thing that I try to emphasize on the topic of topical corticosteroids because clobetasol gets a lot of attention, right?
Mhm.
It is the gold standard for most clinicians. It is going to be the steroid that they start their patients with, but not always. I've definitely heard of some people starting with like betamethasone or mometasone or something like that. But clobetasol is typically like, that's why we see it all over the online spaces, right? And so it kind of reinforces this notion that in order to treat properly, it has to be clobetasol. But that's
Mhm.
not true. Again, we have that ladder of steroids from ultra potent to weak and everything in between. And really, it should be an individualized decision as to which one you're on, right? So, a lot of folks, ultra potent steroids like clobetasol might be too strong. But if you drop them to something mid potent like triamcinolone, then all of a sudden they do very well. Or some people might have a sensitivity to parabens, for instance, and parabens are in the clobetasol formula, but they are not in mometasone. So you switch them over to mometasone, all of a sudden they start responding well again, and they're not so irritated from the ointment. So really, it's an individual decision, and it's one that should be made between patient and healthcare provider, right? Based on how severe is the lichen sclerosus, how is the skin looking, personal preferences, right? Because like I know Kathy, for instance, she's on halobetasol because she doesn't like the texture of clobetasol. Like
Yeah,
that's just a personal preference, right?
yeah. And
She
that's
says like,
Kathy from
yes,
LSSN.
Kathy.
Yeah. Yeah.
I feel like she's such an icon that like I
Yeah.
don't need to like
Everyone knows who Kathy is. We
follow that
do.
up with
Yeah.
like her title or who she is. But yes, Kathy, the CEO of Lichen Sclerosus Support Network. She's also the host of Lichen Sclerosus Podcast. But yes, like her decision to be on halobetasol versus clobetasol was strictly halobetasol feels like lovely lotion and clobetasol is too sticky or something. I don't remember. But
Oh,
I know it was a texture difference and that's it. Right? So the best steroid is the one that works for you and your body.
yeah.
Point blank, period. It is totally okay to be on something a bit weaker than clobetasol. A lot of folks still achieve remission, great quality of life, and are on a mid-potency steroid.
Hmm. What was it called? Halobetasol?
Halobetasol, yeah.
I don't think I've ever heard of that one before. That's a completely new one for me. And I've
Yeah.
never heard a provider talk about parabens in the
Hmm.
steroid, the clobetasol either. So that's
Right.
very
And
interesting.
that I should shout out Dr. Jill Crap for that one. She's the one that kind of brought that knowledge to folks. Again, like she's great at showing nuance when it comes to treatment. Because again, it's not just about clobetasol. Clobetasol is not going to work for everyone. Some people have allergies to ingredients in the base. They need their medication compounded. Some folks have sensitivities and she'll see and be like, oh, maybe there's a paraben sensitivity. Let's swap to mometasone, which is formulated without. And then all of a sudden the patient is well. So yeah, that knowledge comes from Dr. Kraft. So thank you, Jill.
Yeah, no, that's great. And also there's so many different factors playing into it. And I find
Exactly.
that people often feel helpless because they can't find what works for them. And like
Hmm.
taking all this into account, it makes it so much more interesting and just like diving deeper into it too. Because like we're
Hmm.
all different. So I really
Absolutely.
like that. Yeah.
Yeah.
Yeah. If you were to, so if you had that ladder in front of you, you would put clobetasol at the highest, and what would you put
Hmm.
underneath?
It's really kind of complicated because there's many like betamethasone, for instance, like you can get in different potencies. So it kind of
Okay.
depends. If you look at the ladder and like you can Google the steroid ladder, there's a
Yeah.
few online, but like you'll see betamethasone, for instance, is like at multiple places in that ladder because it depends on the dosage for some of these. So it's a little bit complicated in that respect. But again, like the charts make it pretty straightforward. And if
Okay.
you could always like print that out and bring it
Yeah.
to your healthcare provider and be like, I don't think clobetasol is working for me. Can we look at some of these alternatives and have that conversation? Now, I will say that not all providers will be able to have that conversation because they may not have that comfort or extra training or extra knowledge to do that. It does take someone that's kind of well versed in lichen sclerosus to have that conversation. But I think I would hope that most healthcare providers would be able to have that conversation because I feel like that's still pretty basic in terms of like discussions that they should be able to have.
Oh yeah, definitely. And I can put that in the show notes too,
Yeah,
the little ladder so people can find it easily. Oh, I
perfect.
love this. This is golden. These are really great nuggets. That's what we
Nuggets.
need here. So yay. Thank you for
Hmm.
that, Jaclyn. Okay, so we covered steroid treatments. What is a moisturizer that you personally would recommend? What is a moisturizer that you use? What do you see in the community people use? Because this is a question that I get a lot.
Yeah, that's fair. So personally, I use FemSense Balm. It's a Canadian product and it's formulated or it was made by a pelvic floor physical therapist in Ontario. And it is just, I've tried a lot, okay? Like I've tried, because when you're in this space, companies like to send you their stuff. So I've
Mm-hmm.
definitely like tried a nice chunk of of moisturizers at this point. But like I've realized that I'm more of a balmy girl.
Mm-hmm.
I love the texture of like balms because it's kind of like in between an emollient, which is more like oily and thin, but it's not as thick as like a barrier cream, which would be like a Vaseline or an Aquaphor kind of thick texture. It's kind of like in between, but I don't know. It's just so like buttery and like melts so beautifully and like doesn't stain your underwear. There's no odor. I just love that. And if I'm not using that, I'm using plain old coconut oil. I'm pretty
Yeah.
basic when it comes to things like moisturizing. Actually, with LS, in general, my philosophy is to keep it as simple and as cheap as possible. Um, if I need to step up to something more expensive, then fine and fair. But like when the cheaper options work for my body, then I don't really feel like there's any need for me to buy the more expensive things. And
No.
the thing is like you'll look online and there's so many vulvar like balms and emollients and all of these things. There's so many, but it's almost like skincare for your face, right?
Mm-hmm.
There's so many options out there. And when it comes to, moisturizing, I always tell people the best moisturizer for LS is the one that works for you. Point blank, period. It's not something I'm super fussed about. If you want to use plain Vaseline, great. It's excellent. Works as a barrier cream, hydrates the skin, protects the skin. Fantastic. You want to use V Magic? Go for it. It's a great product
Mm-hmm.
too. You want to use these other products. The one thing I will say is that like when you don't go for a single ingredient moisturizer, it can be a bit tricky because you may have a reaction to one of the ingredients in that balm or in that emollient, and it becomes harder to know what is bugging you. Because if I,
Mm-hmm.
some of these products will have like 20 ingredients. And I mean, coconut oil, if it doesn't work for you, straight up,
Yeah.
coconut
Be like, it's
oil
coconut oil. Yeah.
does not work for me. You're using olive oil. Okay, olive oil is not working for me. But when you have these longer lists of ingredients, it can become a little complicated. And I know there's some like Aid, which have like essential oils and things. And I know that for some people that can cause burning and discomfort. And again, just being mindful. If you know obviously that you have sensitivities to certain ingredients or allergies, then obviously look through the ingredient list and avoid those. But typically I'm just like, keep it simple. Like,
Yeah. No, and
you
it's
know,
so true. And we're also different because like I can't do bombs for my LS. Like it and
right.
like I don't even do ointment. I do cream when it comes to my
Yeah.
treatment because
Yeah.
the ointment really irritates the skin for me. So we're all so
Absolutely.
different. Yeah. And that's
Absolutely. That's why I always say, like, you and I probably also have different skincare for our face.
oh
And
yeah.
that's fine
Yeah.
because we have different skin types and we also have different preferences. Like, right? Like for some people, like smell is a big thing. If they don't like the smell of their skincare, they can't do it. Like I
Yeah.
know people that won't use coconut oil because they say, I can't stand the smell. Okay, don't use it. You don't have to use it. There's plenty of other great options out there. Find
Yeah.
what works for you.
Yeah.
Really at the end of the day, like as long as like I'm trying to think, there's nothing like harmful in it, but I can't even think of like what that would be because that still would be an individual thing because what's harmful to some people wouldn't be harmful to others. Like it could be harmful to you if there's an allergen in it and you're allergic to it, but that won't necessarily be harmful to other people. So yeah,
Yeah.
I always say use what works for you. If it works, I'm happy, but moisturize.
Right. Yeah.
Like that's
Do
the bigger thing.
moisturize. Yeah.
That's the bigger thing for me, isn't so much which one, right? It's like the same thing with steroids. Like I'm not so fussed about like if you're on halobetasol or betamethasone or mometasone or use what works for you. You're using your steroid protocol, fantastic. Same thing. You're moisturizing, good.
Yeah.
I don't it doesn't bother me which company you bought your your moisturizer from. As long as you're using it, I'm happy.
Do you use yours daily?
I do.
Yeah.
Yes.
Yeah.
And how often I use it though will depend on a number of factors. So I'll use it less when I have like a day that's back to back at my computer and I'm just sitting all day. So there's not as much friction. I'm just kind of sitting there. So maybe I'll do it once or twice, that's it. But on a day where like I'm going to the gym and then I'm going swimming and then I have like brunch with this person and then I'm running downtown for errands and there's like a lot going on, I might apply it a little bit more frequently. And then also for whatever reason, this has always been the case, but right around the time, like right before I menstruate, maybe like 4 days before, everything like dries up, like Sahara Desert
Mhm.
dries up. There's nothing left. So then I apply it more because I feel dry and dry is not comfy. So I will
Yeah.
apply it more then. But that's
Yeah.
just kind of like based on my reaction to my body's hormones, I guess.
Yeah. And it's about being in tune too and learning your body's
That's
signal. Like
it.
there's so many different ways to work with the condition when it comes to
Hmm.
lichen sclerosis. It's more than just your vulva in itself too. Like getting to
Absolutely.
know your body and yourself. Yeah.
Yeah,
So
that's it. So I kind of like I do, there is a bit of like listening to my body in that sense when it comes to like how often, but I definitely do at least once a day. Yeah.
yeah. Yeah. Okay, well, thank you for sharing that. We are moving on to the next question. So, we spoke a little bit about remission. I had a question that says, it feels like some people get into remission, and how do you define that? Is remission the same as being completely out of symptoms? I'm in a flare, but some days I can feel totally fine and then wake up the next day feeling really bad. It's so hard to work with the steroids when it's not a natural break from for when the flare is ending.
Hmm.
Yeah.
Yeah, so this is definitely something that causes, I think, a lot of confusion in the community. And I think that, how I usually like to approach this is by differentiating between signs and symptoms. So signs are things that you can physically observe with your eyes,
Mhm.
you or your clinician. So this would be things like texture. Is the skin thinned out? Does it look waxy? Is it crinkly? Is it shiny? Does it look thickened, hardened? Are there plaques of skin that, have a different texture? What's the color looking like? Am I observing new fusing anywhere. Those are things that I can see, right? I can see color change. So if there's a white spot, I can see that, but I don't feel the whiteness, right?
Mm-hmm.
Whiteness is not a thing that I can feel. On the other hand, symptoms are things that I feel. Those are going to be itch type symptoms and pain type symptoms. And pain is a massive umbrella, right? That's anything from soreness, discomfort, burning, stinging, right? There's a lot of adjectives that can be used to describe the pain of lichen sclerosus, but pain type symptoms in general, those are your symptoms and those are things that we feel. Now, somebody can't look at you, Penny, and be like, aha, pain. No, we don't see pain on people. Sometimes we can infer it, right? Like if your arm is maybe in a sling, I might infer from that sling on your arm that you may be in pain. Or if you have a cut, I might infer from what I'm seeing, which is blood, redness, laceration, open skin. From that, I infer, probably pain, but I don't see pain. So that's an important distinction because when you hear these big vulvar specialists talk about remission, they are talking about clinical remission. And clinical remission pertains only to the signs. So what that means is that there's no active signs of lichen sclerosus when they look at the vulva. So when they look at the vulva, they are seeing skin that shows no sign of active lichen sclerosus, which would be inflammation, so no new fusing. The texture looks good and healthy. The color looks good. All those things, there's no signs of active disease. Typically in remission, typically, but not always, the itch symptoms go away or are significantly improved. Maybe it's a bit itchy, level 1, 2, if you had to rate it, but like typically you do see those diminish when the skin is in clinical remission. However, you can be in clinical remission and still have pain symptoms. This is something that I talk about a lot all the time. I do one-on-one support calls, and a lot of times this is where I focus the discussion because people are like, the doctors don't know what to do with me. They say my skin looks great and I can just do maintenance, but I'm in pain. And they say, well, you look great. See you in 6 months or 12 months, which is completely unhelpful. And here there's a bunch of things that can be happening.
So, how do we feel about cliffhangers? Because I'm a big fan of cliffhangers. So, you're going to have to tune back in next week to hear the rest of this conversation. If you had any takeaways today, we would love to hear about it. You can find us both on Instagram, me, Wellbeing by Penny, and Jaclyn as the Lost Labia Chronicles. Feel free to tag us in your stories because we'd love to see what you gained from today's episode. Until next week, remember to look after your beautiful body.